I have the great pleasure of introducing today's speaker, Dr. Raman Malhotra. Dr. Malhotra is currently Interim Chief of Sleep Medicine and Professor in the Department of Neurology at Washington University in St. Louis. He also serves as the Program Director of the Sleep Medicine Fellowship at Washington University. Dr. Malhotra attended the University of Missouri, Kansas City for his undergraduate degree and medical school. He then completed his neurology residency and sleep medicine fellowship at the University of Michigan. He has served as the past president of the American Academy of Sleep Medicine in 2021 to 2022 and was on the board of directors for the AASM from 2015 to 2023. He also served on the board of directors for the American Academy of Sleep Medicine Foundation and has served as the president of the Missouri Sleep Society. He has won several excellence awards in prevention from the Brain Injury Association of Missouri and also won the inaugural University of Michigan Sleep Disorders Center Distinguished Alumni Award in 2025. Dr. Malhotra is a sleep medicine educator, teacher, and clinician. He has edited 2 textbooks on sleep medicine and has written numerous chapters in reference textbooks such as Principles and Practice of Sleep Medicine and Fundamentals of Sleep Technology. He has presented and taught on the national level at board review courses at the American Academy of Sleep Medicine and the American College of Chest Physicians. He has also served as course director at courses taught at the national meetings in his specialty. His clinical interests include sleep and athletic performance and sleep and traumatic brain injury. I will now hand it over to Dr. Raman Malhotra, who will be presenting cases that keep you up at night, challenging cases in sleep medicine. Thank you.
Thank you, Dr. Singh, for the really nice introduction. And thank you so much for the invitation to speak at this Grand Rounds. I was able to look online at some of the other past speakers and presentations, and my fellows also are able to look at some of the archived presentations, and they're really wonderful. So thanks for having the Grand Rounds, and thank you for the invitation to speak today. Here's the my disclosure. I did receive a consulting fee, which has ended over a year ago from Axsome Therapeutics. It has no relevance to any of the content I'm presenting today. And I know there's information as far as getting your CME credits as well. Here are the learning objectives for today. And I'm going to go through those quickly only because why reading the cases, right, by showing you the objectives. So what are we going to talk about here in the next, 45 minutes or so? I'm not a researcher like many of you that I see esteemed names here as participants. I'm a kind of a clinical educator. I spend most of my time with the fellows teaching, seeing cases, and as many of you know, when you see these really exciting cases that you either learn a lot about, maybe a good teaching point, in obviously, hopefully, good outcome for the patient. You love sharing those with other providers. And so what I've chosen here is kind of 3 cases. This is a course that I've run at the sleep meeting for a number of years called Cases That Keep You Up at Night. That is the same idea. I haven't done it for a while because I was too busy on the board and doing other things. But I thought maybe I could dust off that and show some of the cases I've saved up in my files over the last, I think the oldest case is several years old, but most of these are actually in the last year. So I mentioned 3 cases kind of with some teaching points that I hope you find helpful. Maybe if you come across it in your clinical setting, or more importantly, I hope it's really interesting and curious and you scratch your head, maybe even challenge what I come up with, because I definitely could be wrong and I'd be open to anything that this esteemed group comes up with as far as maybe other thoughts about the cases. So with that, let's go ahead and start with the first case, which I titled The Case You Have to See to Believe. So this is a 37-year-old woman who presented with sleep-related hallucinations that had worsened over the last about 6 to 8 months when she came to see me. She'd reported that she'd had hallucinations before while going to sleep. So at sleep onset, very rarely, maybe a handful of times in her life. But she says over the last 6 to 8 months, they're becoming a lot more frequent. And she also mentions they're different, which we'll get to. And her sleep schedule is typically falling asleep at around 10:30 at night and then waking up at around 6:15 in the morning during the work week. And she says that typically she'll get these hallucinations when she wakes up from sleep, right around the midnight to 1 o'clock time. And we'll talk a little bit more about what happens during these kind of spells. But she says she'll wake up from sleep and she'll immediately see, she's not sure what wakes her up. She kind of wakes up and then she'll actually see something around the bed, somewhere in the room. And she says it can be very fleeting for seconds, but she said sometimes it's really, really long. And she's even said minutes or even longer, where she'll continue seeing what she's seeing, and she'll remember vivid details of what's going on. She denies that this is a dream. She says, I'm fully awake. If her bed partner's with her, she'll be able to describe what she's seeing to them, although they can't see what's there. She'll even interact with the hallucinations, especially because immediately upon awakening, even though this has happened pretty often, she's still convinced that they're real, because some of them could be real, kind of like an intruder or something in the house, until she finally realizes that maybe this is fake, or sometimes they have very distorted features on their face. So she's not really thinking she is dreaming. She's mentioned there can be bugs on a ceiling. Many times it's someone standing somewhere else in the room, and the person will have either like a really large nose or have some other distorted, sometimes scary feature on their face. And she said it's very vivid. Like I mentioned, she'll wake up her spouse because she's really scared about what she's seeing. She's jumped out of bed before because she thought someone was in her room. Luckily, he's not suffered any injuries, but they are distressing to her, and she wants to know what's going on. She said that one time she was just staring at the person, in this case, that she thought was there, and then really it was there for, she thought, maybe up to 5 to 10 minutes before she even turned on the lights, and that's when the images disappeared, and then she went back to sleep, and she was not with her bed partner that night. She denies any cataplexy or anything that sounds like cataplexy. She denies any sleep paralysis. She has a little bit of daytime fatigue and some mild daytime sleepiness. Her Epworth sleepiness scale was 10. She did report that over the last year or so, she's been snoring, and that's something her bed partner has been complaining about, including some pauses in her breathing as well. Really no other significant past medical history, no home medication. She's completely healthy otherwise, besides what I had mentioned already about these spells at night. She's 5'9", 209 pounds. That gives her body mass index of 31, a neck circumference of 15 inches. She had a Malhotra 2 airway, and her cardiac, pulmonary, and thorough neurological examination were all normal. And so we had studied her with an overnight in-lab attended sleep study. We added arm leads in order to capture any kind of movements possibly that she could be doing, although that we typically add arm leads when we're looking for things like REM sleep without atonia or RBD, and I'm not exactly sure that's what's going on, but we added that. And then we also were going to plan on doing a multiple sleep latency test, given the hallucinations, concern, for example, narcolepsy, which we'll talk a little bit more about as we get into the case. So she did have her sleep study performed. She slept about 7 hours, a little less than 7 hours. She did have obstructive sleep apnea in the mild range, but was worse on her back. You could see her apnea-hypopnea index was 8. On her back, it was as high as 17. Had no periodic lid movements. You can see her minimum oxygen saturation was 88%. We proceeded with a MSLT, which was 11 minutes as a mean sleep latency, so kind of in the normal range, no sleep onset REM period. She had a drug screen, which we do on all our MSLTs, which were negative. But we did capture one of her typical spells, which is probably part of what makes this case kind of interesting. Frankly speaking, the video is not that impressive, but I'm going to show it to you anyway since I captured it. But the PSG data is probably more interesting than the video. But here's the video, and you may not hear the audio, and I know the video is very poor quality as well, but there's not much on the audio, and I'll tell you what she says at the end. But you can at least kind of see what happens here, and you can hear some snoring.
Oh. 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 Nice. I'm up.
So as far as what she was verbally saying, and the tech was able to go in there and kind of ask her, she was fully aware and talking, and she said she was seeing someone in the corner and was asking for the nurse. She initially was just kind of mumbling, but then she eventually was kind of coherent and talking about she wasn't sure if this was real or not real, and was a little bit scared initially, and then was calm and didn't do anything else after that. That was the only event we captured. This is kind of what was occurring during that awakening that I just showed you the video of. And so you can kind of see what looks like pretty clear slow wave sleep, at least what we could tell. This is on a 30-second epic, and you have the big arrow when she awoken from sleep, where you then see a lot of motor artifact. We can also see kind of what looks like the epic immediately afterwards, which looks like she's kind of awake with a lot of muscle activity, and not anything that I thought was too exciting on the EEG there. We can even go down a little further because I knew someone's going to want to see it at 10 seconds. And you can kind of see that arousal, which again, although you may see a little bit of alpha intrusion over the delta waves. Let me get my things here. Nothing that looks epileptiform per se or anything like that I could pick up, and it looked like I guess we'll say an arousal that actually at that time, although she was snoring, looked like a spontaneous arousal from slow wave sleep or stage N3 sleep when she had this this hallucination that she described. So, she had this spell of hallucination about an hour into her sleep, seemed to come out of stage N3 sleep. She started to speak to someone she saw. She remembers this when she was asked. No EEG abnormality with the spell, although I did not do a full EEG at that time. This was kind of a total, a typical PSG, with the 6 leads. Interestingly enough, she did actually have some interictal bursts of slowing, which I'll show you. So not in relation to the spell, but during her overnight and her MSLT, this is at 30 seconds. I was seeing this kind of unusual burst of, I'm not sure what that was, but it definitely stood out to me when I was looking at it. And if we look a little closer, it looked like maybe some EEG slowing. I didn't see anything that looked like sharp waves, and again had absolutely nothing to do with her spell as far as time course. But it did lead to some further workup, which I'm going to get to. But I kind of wanted to take a step back and kind of just talk about hallucinations during sleep, or in this case, even just hallucinations. And then maybe we'll kind of talk about a differential and what happened with this case. So I don't see a lot of people coming in with simply hallucinations. Usually, it's a part of our workup for narcolepsy, or we're just not, it's not a common chief complaint. So I actually learned quite a bit when this patient came in for this reason. So hallucinations, whether sleep or during the day, are sensory experiences that are perceived in the absence of environmental stimuli. Consciousness is preserved, and they may or may not have insight into their unreality. Now, if we kind of go from the hallucinations that probably people in, for example, a psychiatry clinic or an emergency room could see, to sleep-related hallucinations, which in this case, all of hers did occur during sleep, we start to think of other specific things under differential diagnosis. Clearly, narcolepsy, it's the first thing I always think of, and that's what led to the MSLT concern, even though she had otherwise minimal, that was, mild daytime sleepiness, no cataplexy or sleep paralysis. So typically we think of hypnagogic or hypnopompic hallucinations, which I'm going to talk about on the next slide. Someone could have, of course, a psychiatric condition like schizophrenia, or that's having hallucinations day or night. That's definitely on the differential. If it was related to a dream, maybe they were actually sleeping and this was a nightmare. But again, it didn't seem like that by history. Seizures can cause hallucinations as well, though again, really almost nothing else in her spell seems like there's other motor activity, and she had no other seizures that would be consistent with that per se. She did have the EEG abnormality that I mentioned on the limited EEG that we had on the sleep study. Migraines can cause weird visual symptoms as well, though again, in this case, doesn't seem to fit with the history very well. Patients, which again, in her case, seems unlikely given her age, but patients with specifically Lewy body dementia can have hallucinations a lot of times at nighttime when it's dark, although they can also have it during the daytime. And of course, they'll also have cognitive dysfunction and so forth. There's a condition called peduncular hallucinosis, which we're going to talk about in another slide, as well as a condition called Charles Bonnet syndrome or hallucinations, which we'll talk about here as well. That I think, and I'm sure this is by no means an extensive list of things for hallucinations. These are at least kind of what I would come up with as some possibilities, although many that are very unlikely to be occurring in this case that I presented. So if we look at just hypnagogic or hypnopompic hallucinations, again, hypnagogic hallucinations at sleep onset, hypnopompic at sleep awakening, typically later in the morning, and not necessarily how she's describing it, middle of the night. These types of hallucinations or sleep-related hallucinations are predominantly visual, but they definitely can be auditory or gustatory, olfactory, tactile, or even kinetic. And so we don't have to only think of visual hallucinations, although that is the case in the case I presented. It can be difficult sometimes to differentiate between dreaming, and so that really can be because these patients are sleeping at the time. Are they really still sleeping? Are they dreaming? You can see how that can be difficult to ascertain by history. These type of hallucinations are seen in the general population. Some reports up to 40%, even higher. And so obviously on its own is not even necessarily a disorder. It is something we see in patients with narcolepsy or disrupted sleep, but it's also seen in healthy controls. It can occur in conjunction with sleep paralysis. I know that was not occurring in the case I presented, but people can have these hallucinations along with having an episode of sleep paralysis. Higher rates of hallucinations in psychiatric disorders or on patients on psychiatric medications. And it tends to be more at sleep onset versus the hypnopompic. So you see more hypnagogic versus hypnopompic as far as frequency goes. Now, also listed in the ICSD-3 text revision, which is where I took most of that information for the hypnagogic, hypnopompic hallucinations, is they call it a distinct form of sleep-related hallucinations that they call complex nocturnal visual hallucinations, or CNVH, if you're going to abbreviate it, which they describe as rare, meaning it's not very common. And again, this is actually taken straight out of the text revision. Sudden awakening from sleep, no preceding dream. They're very complex, vivid, relatively immobile images of people or animals. Distorted images are common, either in shape or size. May last minutes to over an hour. Disappears with light, may interact or track object. They come out of usually stage out of non-REM sleep versus REM sleep. And the insight is kind of more reduced compared to hypnagogic or hypnopompic hallucinations, meaning they may not necessarily realize that they're hallucinations, and they may actually believe what they're seeing and they may even react to them. And then they list a variety of different conditions where you could see these complex nocturnal visual hallucinations, including idiopathic hypersomnia, dementia with Lewy bodies, anxiety, macular degeneration, beta blocker use, or of course idiopathic. And they do make a point that you should be looking for underlying pathology if this is what they present with, meaning that unlike the hypnagogic, hypnopompic hallucinations, which are seen in normal healthy controls, in some cases, this case, they feel like you should be obligated to kind of search further for a cause. There's an article that also describes hallucinations in general during sleep. You can see this by Dr. Waters and Sleep-Related Hallucinations, Sleep Medicine Clinics 2024. And they have a nice table that goes over pretty much a similar information that I had described in the previous slides, which is looking at complex nocturnal visual hallucinations versus the hypnagogic, hypnopompic hallucinations. And won't go through the entire table, but you can see that obviously, with the complex visual hallucinations, they mention that they have complex images superimposed on the environment, and that they have this negative affective content, meaning fright, anxiety, dread, threatening as a yes, versus the other two are rarely involved. And then they also mention that patients will immediately recall, although again, that is possible in the other two kind of hallucinations, but they typically are forgotten. And you can see that there can be some autonomic hyperactivity as well with the complex nocturnal visual hallucinations, according to this article. Looking further into the literature, and again, as I'm kind of going more into this complex nocturnal visual hallucinations, it does seem like our patient kind of fits this more than hypnagogic or hypnopompic, which we'll talk about. But this was a case series described by Dr. Silber in 2005 of 12 patients. Interestingly, 11 women. So obviously our patient's a woman as well. Mean age of 40. 3 had hypersomnia or excessive daytime sleepiness. They describe these episodes lasting minutes or as long as an hour. Actually, two remembered a preceding dream, which is a little different than what I presented on the previous slides. Six patients were studied, captured three events in one patient, and they were all from stage N2 and N3 sleep. And so they just kind of described this case series of what they consider complex nocturnal visual hallucinations, and that's pretty much what that article describes. And then more recently, in 2018, there was a series of three patients where they actually responded to melatonin, and that was published. And that's a lot of what you can get in the literature on this, so not very much. And then if you look at again, principles and practice, right? I always go back to that too. What do these authors talk about with hallucinations? They actually have a really nice table as well. And I know this is very small print, but it's box 120, I believe. And they are basically just describing hallucinations during sleep. And you can see they also separate them out by the hypnagogic, hypnopompic, and they talk about sleep deprivation and narcolepsy. They talk about drug use like LSD. And then they have complex nocturnal visual hallucinations and talk about a really good variety of different possible etiologies, including some of the ones I had mentioned, like dementia with Lewy bodies, peduncular hallucinosis, this Charles Bonnet syndrome that we're going to talk about, schizophrenia, and metabolic encephalopathies and so forth, Guillain-Barré syndrome, all sorts of different disorders. It's a whole hodgepodge of things that they write here with some references that I find quite interesting as well. But a couple of things on the differential I did want to outline, because at least I wasn't as familiar with them, except for when I came across them reading, which is this peduncular hallucinosis, which is basically from lesions that are typically in the midbrain, but possibly can be in the thalamus or in the pons region as well. And again, this can be a vascular lesion like a stroke. It could be an anomaly in the vascular system, a tumor, even inflammation. And these kind of hallucinations that patients will get are typically stereotyped. They time course with, of course, the onset of whatever's occurring on in the brain. They typically will also have sleep-related symptoms, either hypersomnia or insomnia. They can occur mainly in the evening to nighttime. So again, these can happen during the day. So unlike our patient or some of the other ones, they are more predominant during the sleep hours, but they can happen during the day. Many times there's other localizing signs like a cranial neuropathy. And again, the physiology is thought to be some sort of disruption or distortion to the flow of visual information through the brain. And again, if you did an MRI, for example, you would see kind of a lesion in the brain, and they can present with this pretty unusual presentation of hallucinations. I do remember this after reading about it, because I remember in my neurology residency, if someone came in and was having hallucinations, we always, at least rarely, would think of these kind of lesions in the brain that could cause that. There's also this condition, and I actually don't know if it's Bonnet or Bonnet. Someone can tell me. I have no idea. But he's a Swiss philosopher, apparently in the 1700s. And this is a condition where typically in older subjects, where if someone has severe visual loss, they'll tend to start to see hallucinations, and it seems to occur more when things are dark, so the evening or nighttime. But again, you do not have to be sleeping, and you do not necessarily have to wake up from sleep. And the idea is that this can happen from any lesion in the visual pathway. They're not exactly sure what the physiology is. They consider this a release phenomena, so almost like a phantom limb syndrome. If someone's missing a limb, they get kind of some positive phenomena of discomfort in a limb that's not there. Well, the same idea carries for this, where you're having loss of vision, and because of that, you actually get positive hallucinations from this ocular pathology. So very interesting syndrome. Again, doesn't seem to fit with our patient given her normal exam and age and so forth, but still two very interesting things on the differential that I thought I'd at least share with you, even though I don't think either of those fits, although I'll kind of get back to the case and show you the workup we did. So if we just go back to complex nocturnal visual hallucinations as a group, there's a variety of things that can trigger this, almost the same things that trigger many kind of parasomnias or spells at night: alcohol, drug use, certain medications, beta blockers keeps coming up. Sleep disruption, primary sleep disorders like sleep apnea, periodic leg movements, restless legs, psychiatric disorders, and really almost any other medical disorder as well. And the best we can tell for treatment is, of course, treat the underlying cause of sleep disruption, remove triggers, and then there's a handful of trials of medicines. I mentioned the melatonin case series of three patients. Antipsychotics, of course, have been used given that there are hallucinations involved. Looks like benzos were not helpful in the two patients that were presented in one of the articles I looked at. And then just to make sure that I'm more referring to these complex nocturnal visual hallucinations and not hallucinations that we probably more commonly see in our patients with narcolepsy, which obviously seem to respond to things like antidepressants or other narcolepsy medicines. So kind of after diving into hallucinations, let's kind of get back to my case that I presented. And so I was concerned about the slowing. So I did order a routine EEG, which actually showed spike in waves, interestingly enough, with hyperventilation. But as much as that was abnormal, as I talked to my epilepsy colleagues, they thought that was again, a false positive, not concerning finding with what she's describing and the fact that her spell was captured and had no EEG correlate. She also really has no suspicious seizure activity at all throughout her life. We did get a brain MRI scan, not only because of the abnormal EEG, but because of the differential that I mentioned, and that was normal. We also got her to see a ophthalmologist just to make sure there's nothing ocular going on, and it was a completely normal exam. So as much as that seems like a boring endpoint, she actually was just started on treatment for her sleep apnea, and actually this hallucinations resolved completely with treatment. And again, we made sure she was having no suspicious seizure activity, so we didn't need to start any anti-epileptic therapy given the history. We followed her with serial neurological exams as well, just to see if there's any underlying neurological issue going on, which was not the case. And so I think the final diagnosis was these complex nocturnal visual hallucinations, I guess, from the obstructive sleep apnea, unless you want to call that idiopathic. I think it's from the sleep apnea. I had never seen that being caused, out of the, I guess, hundreds, if not thousands of sleep apnea patients that I've heard about, but was a very unusual case that I wanted to share. And what I'm going to do is I'm actually going to go on to the other two cases and leave time at the end to discuss. So make mental notes or written notes if you have questions about these cases, because I do want to try to get to all of them. So hopefully you'll follow that plan there. So I'm going to move right on to case 2 and 3, which are shorter, and I think we'll be able to fit these in here. Eric is a 45-year-old male who had a head injury about 7 months ago. I saw him in clinic, so 7 months prior to being seen in clinic. He was at work, and it was a severe injury in the sense it caused a frontal sinus fracture. He had resulting sinusitis and is actually being followed by ENT for these kind of infections that were as a result of the injury. He also developed these abnormal movements in his extremities and trunk that really only occurred either when he was sleeping or as he was falling asleep. And that's how he ended up in our sleep clinic. He said that he's actually fallen out of bed. He's hit the wall with his arm. He's kicked a wall as well during his sleep. And actually, due to these kind of weird movements, his wife was no longer able to share his bed with him, and she actually moved out of the bedroom. The movements will actually wake him up, especially if he hits the headboard or the wall or an object next to him or falls out of bed. He was also having headaches and personality changes since his head injury. He was very sleepy. His Epworth was 17. He said he's never feels rested anymore ever since he's had this accident. He was having drowsy driving, drowsy with sedentary activities. He says he does snore, but he said that's long-standing prior to even the injury. No apneas during sleep. He does have daily headaches, though. Again, that's ever since the injury. No cataplexy, hallucinations, or sleep paralysis. He reported some mild RLS symptoms when we asked about him, but they seem to be very minimal. And did not seem to cause much sleep disruption per his history. You can kind of see his sleep schedule here of falling asleep at 10, waking up at 5, 20 minutes to fall asleep, fragmented kind of 2 to 5 awakenings that are brief at night. He's using trazodone every night. And he says that, again, prior to even the head injury, he had kind of ruminating thoughts at night, and his psychiatrist had put him on trazodone. He does have a history of anxiety and depression followed by psychiatry. He also has type 1 diabetes, Crohn's disease, hyperlipidemia, and he had seizures as a child, but has not been on seizure medicines for years. You can see his list of medicines, many of which were started because of this injury. So he's on amitriptyline for headaches, amoxicillin because of those infections. He's already been on citalopram and bupropion before. He's on albuterol, insulin, montelukast, omeprazole, and he was started on gabapentin for these movements by someone in the emergency department a while back. Really nothing else exciting on his family history or his social history. He works as a mechanic, which is how he had the head injury. You can see his exam, his body mass index is 29.4, pretty tall gentleman, neck circumference 16.5 inches, Malhotra 2. He was had a thorough neurological examination, which was normal besides this finding called Hoffman's, which again, I would never do a Hoffman's on my sleep patients, but this he was seen by neurology prior to me, which I'll get to. And Hoffman's is where you kind of are flicking the fingers and looking for some kind of extra contraction of the finger muscles, flexion. And it's really just a sign of upper motor neuron either damage or irritability. So he didn't have that bilaterally, but otherwise had a completely normal exam. Okay, so a little bit more about what happened. Because before he got to me, he'd already seen a lot of other doctors. So about a month after the injury, remember I saw him 7 months later, or 6 months later after that, he was seen by our neurology team in our at our hospital at Barnes Jewish Hospital for headaches. And they actually noticed this myoclonus as he was sleeping in the emergency room. So they actually obtained an MRI that was normal. They also did a spot EEG. They were able to hook him up in the emergency department and did not see any EEG correlate, even though they captured these jerks in his extremities. He was seen in follow-up at our movement disorders clinics. They, again, were not thinking this was epileptic, and they thought this was some sort of movement disorder. That's when the movement disorders tried to discontinue some of his medicines, thinking that maybe this was contributing to some of the movements. They were mainly blaming his traumatic brain injury as a cause of myoclonic jerks. And then when he followed up with them 3 months later, again in our movement disorders clinic, they thought he was slightly better, but they actually saw him have a myoclonic jerk in his during the exam while awake. And so they, because they were predominantly happening during sleep, decided to order kind of a direct order to the sleep study, which is when I got involved. So they had ordered a full polysomnography with full EEG, and you can see that he didn't have a great night of sleep in the lab. He did have obstructive sleep apnea, so his AHI was 14, again, worse supine. Didn't have many periodic lid movements at only 0.7 per hour. He snored almost the whole night. He also had abnormal movements as described by his history, and I'm going to kind of show you that. He also did have REM sleep without atonia, which I'll show you. So I'm going to show you the video of, this is actually during REM sleep. So the first video clip I'm going to show you is, again, when he's in REM sleep, and I'll show you the epics as well, but let me get this to work here. The movements are not that prominent, but I'll also show them to you because they're pretty frequent, and you can kind of see them in the legs, kind of his trunk there. And you'll eventually see his arm kind of swing a little bit. So we captured a little bit more vigorous than obviously we'd like to see. And he kind of hit his hand on our dresser that's next to the bed. So again, nothing more vigorous than that we saw that night, but definitely not normal. And this is kind of what the epics look like on the sleep study. So you can see some pretty clear rapid eye movement sleep. And you can see that in his legs, he was having quite a bit of muscle activity, really not much in the chin. This is one of the epics. Here's another epic. And again, pretty much all his epics in REM had pretty close to meeting REM sleep without atonia, or they met criteria, just about every epic. So pretty high tone, kind of consistent with at least what possibly could be REM sleep behavior disorder. He didn't really describe a lot of dreaming that he remembered. That was the one part, but otherwise that seemed to be consistent. And then during sleep-wake transition, because again, he also described not just these movements where he would injure himself, but he would, as falling asleep, would have these movements, maybe what they saw even in the emergency department when they were initially seeing him. So we were also able to capture that. And this is, again, when he was actually awake or going into N1 sleep. And you can kind of see these kind of quick, almost looks exactly like what he was doing in REM, but it's not in REM. You can see these quick jerks of his legs, a little bit of his arms, a little bit of his trunk. And he basically did that throughout the night during kind of sleep-wake transition. And again, he would deny that was his restless legs, although he did describe that he had some restlessness. He was even asleep during part of this, and they didn't really meet criteria for periodic lid movements because they were constant. Okay, so he did end up getting $1 million workup, partly because he'd already gotten to us before. He already saw several other specialists before seeing us. My colleagues in the neurology department were very concerned about an autoimmune disease, given his myoclonic jerks and his history of type 1 diabetes and Crohn's disease. And so you can see that he had lumbar puncture, very extensive autoimmune workup. Long story short, all of which was negative. And I have everything listed here. He also underwent neuropsych testing because he was complaining of memory issues after the head injury, and they felt like this was more secondary to pain and mood. He was also seen in our kind of general neurology clinic, which is people who follow people with concussions so they could help resolve his headaches. They end up getting, because he just wasn't getting better, end up repeating a lot of the testing, including his MRI again, which was normal. From this as a sleep perspective, started AutoPAP again, and he actually had pretty good adherence. His download looked good, but honestly, his movements really did not get any better. His headaches didn't get any better. Really, he had a little bit better quality sleep, but honestly, was not any better. And that's when I decided to start him on clonazepam. One, because at least I was told clonazepam works for every movement, right? That's the cure all for all parasomnias. But joking aside, I think these were he obviously has RBD, REM sleep behavior disorder, at least based on what I thought was movements during sleep and REM sleep without atonia. And then I think the jerks, he has these kind of hypnic jerks at sleep onset, sleep myoclonus, maybe secondary to his TBI. It's definitely been reported in the literature that traumatic brain injury can cause just poor sleep in general, including exacerbating or even causing different parasomnias, including hypnic jerks. And so that was my theory, given that this all occurred after the head injury and that hopefully this would resolve as his head injury resolved. But the clonazepam, which actually did help reduce the movements, they weren't completely gone, but they were enough to where his wife could sleep in the same bed with them. And so that's where we kind of left that case. But I thought it would be a reasonable thing to discuss at least TBI in sleep, something like that. I know the person who introduced me, Dr. Singh, mentioned is one of my interests. And so patients who suffer traumatic brain injury, like this gentleman, very commonly will have sleep complaints, and in reality can be almost anything. It can be hypersomnia, which is probably the most common, but it definitely can be insomnia, fatigue, and or parasomnias. And it can be, interestingly enough, acute with the head injury like this patient, or even chronic. And it's a very interesting study that I cite here from 2009 that looks at the incidence of different sleep symptoms after the head injury. And what you'll see is that even as late as 3 years later, you're seeing a lot of these symptoms, some of which are actually more likely years later. So it's one of those injuries in the brain that definitely can cause acute symptoms, but may persist for chronically as well. And probably the other kind of take-home point with the TBI and sleep is that really any sleep disorder has been triggered by this, whether it's obstructive sleep apnea, central sleep apnea, narcolepsy, the post-traumatic hypersomnia, which can look like hypersomnia on the MSLT, but they don't have a lot of the REM-related phenomena of narcolepsy. RLS, periodic limb movement disorder, insomnia, circadian rhythm disturbances, including alterations in melatonin levels, and then parasomnias, whether it's sleepwalking or REM sleep behavior disorder, has also been associated with traumatic brain injury. So I thought this was an interesting case of a traumatic brain injury that I think triggered these unusual movements, including RBD, although again, really the approach to him was pretty direct of what we would do even if they didn't have TBI, though he clearly had a pretty extensive workup for other things as well because of these unusual movements. Okay, so the last case, which is very quick and was more in case if I didn't time everything else there. I did want to leave some time to discuss things, so I know we have about 20 minutes. But I'll definitely leave some time here, is maybe less of a conundrum and more of something that I see in clinic all the time that I still struggle with, and I was curious what people's thoughts are as well. So old habits are hard to break. So this is a 66-year-old woman reporting snoring, witness apneas, excessive daytime sleepiness for the last 2 to 3 years since gaining weight. She has an upward sleepiness scale of 14, rare drowsy driving, sleepiness with sedentary activities and quiet conversations, has a past medical history of GERD and hypertension. BMI is 32, has a Mallampati 4, and so a split night sleep study was ordered. And her PSG findings, her kind of, we'll call it 4% AHI, or if you want to call it Medicare or CMS, was 4.2. Her, we'll call it ASM, or if you want to call 3% or arousal AHI, was 11.3. You can see that during REM sleep, both of them were higher, but you can see it was as high as 22 during REM sleep. Really no positional component. And so really this is just a good case that at least I come across all the time, or what do we do with these patients that meet criteria for obstructive sleep apnea based on 3% or arousal, but not the 4%. And so, we have this kind of different hypopneas, different diagnosis conundrum, I guess we'll call it, right? So what about these events that are not causing desaturation, but are causing fragmentation or disruption of sleep? What do we do with these patients? And I will kind of tell you my perspective on this and a little bit of data to describe some of the challenges that we have with this type of patient that, like I said, I run into all the time. There's lots and lots of data on this. I'm sure this could be its own talk, and maybe you guys have already had a talk on this, but this is looking at the Sleep Health Heart Study data, where we separate the data into, well, I guess we'll call it the 4% or Medicare criteria in the first set of data here. We have, if you just add 3% on the second column here, and then 3% arousal on the last set of data. And what they're looking at is, let's just look at the normal, for example, and you can see that using Medicare criteria, 47% were normal, but if you start to add the 3%, suddenly now it's just 29% that are normal. And then if you add the arousal, it gets down to the 16%. And so our patient, for example, you could see was part of that group that went from 47 down to is now at this point in the mild category, right? So that you can see that there's quite a bit of shift based on which definition you use. Again, I would imagine this is something that you've already discussed and are aware of, but it is interesting to see that the numbers in a data set like the Sleep Health Heart Study. I think what's maybe more telling is who are these people that are not desaturating and having the fragmented. And what we're noticing in a good number of studies is that this does tend to be like the patient that I presented, a woman, as it does seem clear that they don't necessarily desaturate with their events as much as men. Younger patients, non-obese patients, and then I put other. There was a nice, interesting article in the Journal of Clinical Sleep Medicine for December, just fresh off the press, looking at oximetry and in patients with darker skin color. And so are we, when we're using the 4% desaturation, are we missing patients with darker skin color where maybe we're not accurately capturing the 3 or 4% desaturation and maybe missing the correct diagnosis in them if you're using more stricter criteria? There was an article just recently in 2025 also looking at the exact same point that I'm making here, which is that if we look at using different criteria, again, Medicare versus non-Medicare, and looking at kind of no SDV diagnosis, you can see that though both in men and women, you're going to end up, I guess we'll say undercalling obstructive sleep apnea when using the 4%. So for example, 27% of the males would have it with using Medicare criteria, but you would add another 5%. I'm sorry, you'd add another 22% if you included the arousals or 3%. You can see in women, it's actually even a larger percentage. So again, we seem to be missing more women than men if you look at a gender disparity there. And again, maybe the picture will be maybe a little bit more telling in both blue and pink, the blue, of course, being males and the pink being females. You can see that although by changing hypopnea definitions, you're going to miss patients in both groups, you do tend to miss a higher percentage of females where they're going to meet criteria using kind of the recommended 3% arousal definition and not the Medicare definition. There's a nice accompanying article to the one that I just presented that was in the JCSM earlier this year, editorial by Dr. Tarian and Dr. McCullough, kind of mentioning that this kind of strict hypopnea criteria exacerbates health disparities in females. And to summarize kind of what they mentioned, emerging and older data demonstrate that treating OSA defined by arousals or 3% leads to improvement in quality of sleep, EDS, and hypertension, amongst other things. And that women, although present differently than men, we tend to call it atypical presentation of sleep apnea, meaning maybe they have insomnia, maybe they don't have the desaturation, but is it really just atypical, or is it just atypical from when they were initially described back in the day of the 80s, 90s, when they were only testing men for sleep apnea? I'm not going to go through that much more on this topic, but wanted to at least have on the slide. There is pretty good data that the 3% arousal is associated with symptoms, although again, it is a debate, and obviously there's multiple reasons why certain payers are going to use one criteria over the other, including economical. But when I was on the board, this did lead to a position statement where we recommended that labs use arousal-based scoring, meaning that yes, they should probably also include the 3%, but it was critical that they look at arousal-based scoring if they're wanting to capture patients that are symptomatic with obstructive sleep apnea. And actually, the idea was that they would actually, when the new scoring manual would come out, which it did in 2023, that the kind of, I guess I'll say subtle change, although that's the reason I bring it up here, is that Medicare criteria has always been in the scoring manual, and it was usually described as acceptable, meaning that you could do it instead of the recommended criteria. They actually moved from acceptable to optional, which in the scoring manual, optional means that you have to do it in addition to. So the idea behind the change was that if you're an accredited ASM lab, that regardless of payer, they would at least have to do the 3% arousal. Again, even if the payer doesn't recognize it, at least you're giving the information to the patient to be aware of their diagnosis and treatment plan, even if not covered by the payer, versus undergoing, for example, full polysomnography and not even capturing that hypopnea. For example, what if the patient changes their payer and now you don't even have that data? So this is my second to last slide because I'm more interested in kind of seeing what other people want to talk about from the cases. But some of the challenges that I have with the different OSA criteria is what do we do with these patients that meet one criteria and not the other? And for even worse, what if they change payers, and how do you document that? We had also noticed when on the board that most labs were not counting 3% arousal. They were only doing Medicare when we did a survey. And so the hope was that the scoring manual change will at least allow you to do hopefully both, if not at least the 3% arousal. And then the other challenge that we had is it was very difficult to find out which payers use which definition. Clearly, Medicare uses the 4%, but what about all the other private plans? And even when trying to reach out in our own regions, we were having discussions in which criteria each one uses, and it was almost impossible to get a straight answer, which is another challenge. So with that, I'm going to go ahead and just get to my last slide here, and would be happy and excited to see what people are thinking and talking about. I'm going to probably stop sharing my screen so I can see you a little bit easier too, if you don't mind.
Thanks so much for this talk. It was really good. I haven't had listened to a talk about hallucinations before, and knowing the different, like the extended differential for it. Most of the things I think about are like dementia, Lewy body, beta blockers, but I didn't realize, thinking about macular degeneration and things like that can cause hallucinations. And I agree that 3% versus 4% rule is very frustrating. And I don't know if I have anything smart to say about how to deal with it. I just try to take it patient by patient. I don't know if anybody else has any questions or comments they want to break up.
I did see Dr. Yagi had asked about if there's any association with childhood parasomnias. I was not able to, because there's just such little information on this complex nocturnal visual hallucinations that all I could find in the literature was literally what I presented, which is very little. I was a little surprised. So I have a feeling it's more common than we think, because at least I wasn't fully aware of even how to accurately describe hallucinations. So I'm sure I've probably seen them and just assumed they were the typical sleep-related hallucinations that we get from REM.
Yeah. Thank you, Raman. I'm just going to add regarding that last case, that is such an important issue, the AHI 3 versus 4%, and how it systematically underdiagnosis and therefore undertreats sleep apnea in women. And I think you've been involved with this as well, but Project Sleep has created this forum, I think, for the ATS, AASM, other sleep societies to go to the Hill. And this year, that was a major issue. I know we've been trying to get CMS to change this for over a decade now. It's interesting that Medicare continues to do this, and most of the other private insurers in our area accept the AHI 3%. So it's almost flipped compared to where what it usually is. But this year they took a different tact and circulated a letter for congressmen and senators to sign that would go to CMS. Instead of going to CMS directly, we're sort of going above their heads to Congress to get a letter to say that they really need to act to change this. So such an important issue.
Yeah, no, I agree. And I have heard of a lot of those movements, which are really good. That was, as again, I would say that I think I joined the board in 2015. This is something that bothered me as far back as that, and it's extremely slow moving. Again, I'm not a researcher, and I was taking it from kind of the ASM side with advocacy, and we definitely try. We talked directly with Medicare and got nowhere, and so I do think this other strategy is probably going to, I'm hoping, more effective. And what we were seeing, and you are correct that every region is different because at this point, all of our insurances also accept 3% or arousal. But we had an interesting phenomena where United Healthcare in the Missouri region, I guess, decided to go to 4% just suddenly. And so then at least that's what we were told. Like I talked to someone from them because again, you could tell this is a topic of interest to me. And suddenly these patients who already had sleep apnea now don't. And so they couldn't get masks into, I mean, it was a really weird, and it was actually the insurance that everyone at our university uses. So even like people in our sleep lab were, including staff and clinicians in our medical practice are suddenly don't have sleep apnea now, which I thought was kind of shocking. And they quickly reversed once we, kind of talked to them. But it was odd to think that would, it was going to be a cost saving move, of course. And I believe it or not, I think the reason they changed course, which is really sad, but is that it led to more in-lab studies because, of course, on our home testing, if you use 4%, now suddenly you're having to do more in-lab. So they realized that they're actually just losing money. Yeah, they were just looking only at the dollars, and whoever was bean counting decided, oh, maybe it's really not that much of a cost saving.
That works in our favor.
Yeah. So it was kind of interesting that that's how it does, and even things like MSLTs, and I was trying to explain to them that we're not going to leave the sleepy person sleepy. We're just going to keep looking. So you might as well just CPAP and see if they get better. Yeah. So, but I don't think that was working for Medicare. But the other thing I'll mention with this topic, many layers, and I know that the AHI in general is limited, and should we have another index? There's all sorts of very exciting topics, and so it is something, like I said, that I knew that we could fill time talking about, and you'll see that the sleep meeting as well. And I'm glad though that there's some advocacy. I'm really excited about that.
Yeah. The letter's going to Dr. Oz, so I wouldn't be so excited about it, but we'll see what happens.
Yeah, it's a good idea to try to pick people who have sleep apnea that are senators or House of Representatives. That was kind of a strategy we were thinking about.
Thanks for sharing those wonderful cases. They're fantastic.
I had a question about the second case you presented. It kind of reminded me of propiospinal myoclonus. And I was wondering if I couldn't remember if you did like a spinal MRI or if that would be something to do next potentially to see if there's something going on there, contributing to symptoms.
That's a great question, actually. And he also had, if I'm remembering correctly, that Hoffman sign, which would mean that typically points to the cervical neck area. He actually did have, because of his injury, he did have neck imaging that was kind of unremarkable. I didn't put that on there, but it was kind of not ordered by any of us, which is why I didn't do that. But that's a good thought, and seemed a little. I don't know. If that's exactly, the only propiospinal myoclonus I've seen is all these like classic ones that are presented to, and so maybe that's like it just didn't look like it to me, but I think that's a reasonable thought as well. It's almost in the same realm of what we're trying to treat, so I'm not surprised it would go away with with the benzodiazepine. Yeah, what I've noticed though in my TBI patients is that they do become just twitchier in general, and their sleep is just very disrupted. And so very similar to maybe someone who's ill or sleep deprived, where everything gets a little accentuated, including their movements. And so that's kind of the way I kind of compartmentalize in my head is that this person just had a severe brain injury and it's, everything's going off. He's having headaches and mood changes and his depression's worse. And so now he's just kind of twitchy and we need to kind of cover him until he resolves.
That's does anybody else have any questions? All right, if not, then I think we can wrap up, and thank you so much for this amazing talk.
No problem. Thank you so much for the invitation. You guys have a good rest of the week.
You too. Bye-bye.
Bye.